consultant paediatric allergist. Why is cow's milk protein allergy important, and why are the numbers rising?
Cow's milk protein allergy is important firstly because it's very common. It's estimated that around 2% of UK infants will suffer from immediate type cow's milk allergy and similar numbers suffering from delayed type cow's milk allergy. Now the symptoms that these allergies can cause can have a real impact on quality of life. They can be very unpleasant, particularly if the diagnosis is delayed, which makes it particularly important that doctors in primary care are able to recognise the symptoms and make a prompt diagnosis. There's not much evidence to suggest that there's more cow's milk allergy than there was in previous years, but I think it's becoming clearer that we're getting better at recognising it. We're also recognising cow's milk allergy in the broader sense, not just the obvious and immediate type reactions with urticaria and angioedema, but also the delayed type allergies that can present with colic, reflux, diarrhoea, faltering growth. And as we recognise those better, not only are we improving kids' quality of life, but we're also seeing more and more cases as a result.
It's clearly very important to understand the difference between IgE-mediated symptoms and non-IgE-mediated symptoms. What are you looking for in the history to help you distinguish between them?
I think the distinction between IgE and non-IgE-mediated allergy when it comes to diagnosing milk allergy is absolutely key. IgE-mediated allergies are usually quite straightforward to spot. There'll be a history of exposure to cow's milk protein. It's often the first bottle of formula that the infant's had. And then very soon after, usually within minutes, there's urticaria, angioedema, and all the typical features that you expect of a classic allergic reaction, because that's what this is. It's an IgE-mediated type 1 hypersensitivity reaction. Delayed type or non-IgE-mediated allergy is much trickier to spot because there's not the clear relationship between having the milk and seeing the symptoms. In fact, usually what's happening is the infant will be having cow's milk regularly in their diet, and as a result they'll be getting chronic symptoms. And those symptoms could be chronic eczema, it could be reflux, it could be colic, it could be diarrhoea, faltering growth, food aversion. There's a whole array of different symptoms that could be due to food allergy. But the real challenge, of course, is that these are all symptoms that are common in infants. GPs all the time see children with those symptoms. Only some of them have got an underlying milk allergy. And the key of taking a good history is to be able to differentiate which of those kids actually might have the underlying food allergy. And if you suspect that it's an underlying delayed type allergy, that you're going to do the right test, which is excluding cow's milk from the diet with the help of dietitians, then reintroducing it to see whether the symptoms get better when you cut the food out, whether they deteriorate and return when you reintroduce the food. And when I take an allergy-focused history off a child where I suspect a food allergy, I'm asking two questions. The first is, do I think there is a food allergy? But the second is, if there is a food allergy, what's the underlying mechanism? Because if it's an IgE-mediated allergy that I suspect, I'm going to do allergy testing, skin prick tests or specific IgE blood tests. If I'm suspecting a delayed type allergy, I'm going to go for the exclusion and reintroduction.
There are always pressures on primary care to refer as appropriately as possible. Are some of these patients safe to be managed in primary care? Is there a risk of some of them going through anaphylaxis, for example?
I think it's probably unrealistic to say that everybody with a milk allergy needs to be referred up to a specialist service, because that's not happening, and I don't think there's capacity in the services for that to happen anyway. The challenge is to get the right kids sent up to specialist care and manage the right children in primary care. And yes, I do think there's a lot of scope to manage children with milk allergy in primary care. In my mind, there's 4 good reasons to refer a child up. The first would be if they've got multiple food allergy. If it's not just milk, if there's other foods involved, that makes it very challenging to manage effectively. It needs a lot of dietetic support, and the best place for that is probably secondary or tertiary care. Other circumstances are if there's severe allergy. So for example, with immediate type allergies, if the child's at real risk of anaphylaxis, so if they've already had a nasty reaction that had cardiorespiratory features, or if they've got asthma as well as food allergy, that increases significantly the risk of them having a nasty reaction. Those kids should be managed in secondary care. Whereas with delayed type food allergies, often the symptoms are much milder, so it's much more reasonable to manage those in primary care. However, some kids can have nasty reactions too, even though they're delayed reactions. They're still very unpleasant, and the symptoms can be severe and have an impact such as faltering growth. So I think the severe end of delayed allergy, albeit the minority of these kids, they should also be referred up. And then the other circumstance where I'd encourage GPs to refer patients up are when the history and the allergy tests just don't quite stack up. So you've got a child who appears to have had a clear immediate type reaction, yet the allergy test, the skin test, the blood test was negative. Or you've got what appears to be a clear history of eczema or resistant eczema, resistant reflux, where you suspect an underlying milk allergy, yet when you exclude milk from the diet, you don't get the response that you expect. Those more challenging cases, they also warrant a referral. But children with mild allergy, particularly delayed type allergy, where there's a flare-up of reflux or colic or eczema, and that's it, then I think that's perfectly reasonable for that to be managed in primary care, as long as the doctor feels competent and confident to do so, and essentially also that they've got dietetic support for that management as well.
How important is testing here? Should these children have skin prick tests, IgE blood testing in all cases?
If you suspect an immediate type allergy, I'd be recommending that every child had a test. And in primary care, as you've said, specific IgE blood testing, what used to be called RAS testing, is freely available. The benefits of testing are numerous. The first is that you get a confirmed diagnosis. There are other reasons infants can come out in hives. So whilst the history is usually quite clear, a positive test gives you a confirmation of your diagnosis. It clinches it definitively so that you know exactly what you're dealing with and you can get the appropriate dietetic input after that. Also, we expect most children with milk allergy to outgrow their milk allergy. And the allergy test for immediate type allergy is how you're going to guide when the right time has come for reintroduction. So you need a baseline. As it happens, once you start becoming more familiar with allergy testing, it's often quite useful information to have, because the size of your allergy test at first diagnosis often gives you an idea of what the likely prognosis is for that milk allergy. Children with small allergy tests at diagnosis often outgrow the allergy earlier. Children with larger allergy tests at diagnosis often have a more protracted course. What's also important to understand is the limitations of allergy testing. If you've got a large allergy test, it doesn't mean you're going to have a severe reaction. There's no relationship between the size of the allergy test and the severity of reaction that you might have.
Sue, you're a health visitor. These patients often present very early in life and they often present in the community. What sort of things are you looking for in the symptoms they present with and in the history that you take?
Okay, we see a great many babies presenting really very early on, always in the first year, I'd say, with a range of symptoms that can be from just a mild nuisance right through to very severe indeed. Things like colic, gastroesophageal reflux disease, constipation and diarrhea, sometimes in the same patient, abdominal pain, back arching during a feed and vomiting after a feed. Also lots of dry skin and eczema developing, sometimes even, or quite rarely I suppose, urticaria and angioedema, and then respiratory symptoms as well, like coughing, asthma, wheezing type symptoms in tiny babies, and even babies coming floppy and weak, although I don't tend to see those very often. So it's really those ones we're looking to see whether they're a type 1 allergy or a more delayed reaction coming on. And if I suspect a baby it seems to be displaying symptoms of perhaps a cow's milk allergy, the thing we normally do is take a detailed history first of all of what's actually happening to the child, details of the symptoms they're getting. We also want to know whether there's any family history of allergy, and there frequently is in the parents or siblings, or even earlier on in the child's own history as well. We're also wanting to know in detail what the symptoms are. For example, are they getting projectile vomiting? Is there any blood in the vomit? Is it lots of vomit coming up or just small amounts? And is it affecting their growth and development? We're also want to know what their stools are like, whether there's lots of blood or mucus in their stools, and whether they're getting lots of abdominal pain.
If you've identified a patient with possible cow's milk protein allergy, how do you then proceed?
So I'll be usually working quite closely with my GP colleagues at this point. Hopefully my history taking has identified babies who are having a type 1 allergy, an immediate type reaction. And obviously those patients would need to be referred to a paediatric allergist. So I'll be working with my GP colleagues to get them referred. And when they see a paediatric allergist, they'll need a full assessment, including a risk of having a severe allergic reaction. For the other babies, the ones with the delayed, perhaps non-IgE mediated reactions, unless they're complicated, they can often be managed in general practice. with the exclusion, and all of these babies will need to have cow's milk removed from their diet. The immediate type reactions, and it needs a complete exclusion with no chance of any molecules getting through. With the other non-IgE, that they often do very well just by removing, just by putting them onto a hydrolyzed formula, or sometimes mum has to remove it from her diet if she's breastfeeding. The big thing, I suppose, is that we really must have a referral to a dietitian to actually help support them, make sure their diet continues to be nutritionally sound.
Lisa, you're a community paediatric dietitian. If a GP or a health visitor refers one of these patients to you, what are you looking for in the history?
Right, I'd be looking at 3 key organ systems: the gut, the skin, and the respiratory systems. In the gut, there are some key red flags for me: the presence or absence of mucus and blood. That would suggest there's inflammation going on. Frequent loose offensive stools, and maybe nappy rash as well, excessive flatulence, commonly reported to me. Rapid gut transit, so the milk or food is almost sort of going straight through the child and out the other end. Constipation in the first few weeks of life is really uncommon, particularly in breastfed babies. And so whilst ruling out physical causes for that, allergy should also be suspected. Alternating constipation and diarrhea is also another typical pattern that we would see. Abdominal distension that often tends to get worse during the day. And more immediate symptoms, projectile vomiting almost as soon after they've had the food or drink is also common. With the skin, some of the most common thing I'd be looking for is eczema in the first few months of life, particularly if it's moderate to severe eczema that needs treatment with steroids. Other blistering rashes that seem to occur fairly soon after ingestion of the food. And the typical sort of immediate type reactions, urticaria or angioedema. From a respiratory point of view, commonly parents will report to me that they have a constant runny nose, or they always seem to have a blocked nose. They're sort of typical things. They are chesty all the time, or the more common symptoms of asthma, the wheeze that you might get. And I would combine all of that and look at the family history of atopy, and you usually find a pattern of eczema, asthma, hay fever in parents or siblings as well, or other food allergies. And one of the other things that's often reported to me is, oh yeah, I had lactose intolerance as a child. And you know that actually they're talking about the fact they also suffered from cow's milk protein allergy in infancy.
Lisa, if you're suggesting a period of cow's milk protein exclusion from a patient's diet or from mum's diet if she's breastfeeding, how do you go about that, and what are the possible pitfalls?
Okay, well, if the baby's on formula, then we would use a hypoallergenic formula. However, if the baby is reacting to the traces of cow's milk present in breast milk, then they're clearly quite sensitive to cow's milk, and mum would need to go on a very strict cow's milk protein-free diet. This needs to be done very carefully with lots of dietary information to support her to be able to read labels. There are hidden foods such as processed meats and sausages and things like that where milk can be found in. And making sure that she gets enough energy and protein and calcium back into her diet from what she would have lost by cutting out the dairy products. To get enough calcium in her diet, mum would need to use a litre or so of soya milk or oat milk substitutes, and that's invariably difficult to achieve. So we usually recommend prescription of calcium supplements and alongside vitamin D if they're not already taking it.
So if I'm a GP and the patient presents to me, or the health visitor sends them to me first, should I be referring to you directly before advising any exclusion of cow's milk, or can I start the process myself and refer so you pick the patient up halfway through?
We wouldn't want to delay the diagnosis, and waiting for a dietitian to be able to provide that information will inevitably cause a delay. So what we would prefer is that some individualised dietary information was sent to yourselves or the health visitor to go through with the family to support them in the interim through that process. And then if it proved to be beneficial, a referral to the dietitian then made.
There are lots of different available formulas, and I'm aware of extensively hydrolyzed formula and amino acid formula. What's the difference, and when would you choose each one?
Right, okay. Well, extensively hydrolyzed formulas are derived from cow's milk, and therefore there are trace amounts of cow's milk present, although the majority of infants will tolerate these products, and therefore we would normally consider using these first line. The only other difference between the extensively hydrolyzed products is the presence or absence of lactose, and lactose can make them much more palatable, and therefore we would be considering whether we could use those first, as they are more likely to be taken. However, if there are lots of gut symptoms, lots of loose watery diarrhea and that sort of thing, then we may actually go for one without lactose. Amino acid formulas, however, are synthetic products derived from its individual amino acids and therefore bear no relation to cow's milk whatsoever, and we would be using those for children most sensitive to cow's milk allergy.
So soya milk wouldn't be an appropriate change to suggest?
Yes, soya milk should not be used in infants under 6 months of age due to the isoflavone content, phytoestrogens, and infants under 6 months have a greater amount of that per kilo body weight than anybody else in the population, so we're not to use those in those children. There is also a great risk of cross-reactivity between cow's milk and soya milk in infants with gut allergy. And therefore we wouldn't want to be using that either.
And you mentioned lactose earlier on. We're not talking about lactose-free formulas here, are we? Because they're available.
Yes, no, we're not, because lactose formulas are based on cow's milk, and so they're not suitable for cow's milk protein allergy. And whilst they have been prescribed with a degree of success in infants that have symptoms of lactose intolerance, which will be secondary to a cow's milk protein allergy, so your loose watery stools, abdominal distension and flatulence, it won't resolve the more immune-related symptoms they might have of eczema or mucus in stools and that side of things.
As a GP, I'm often unsure about how much formula I should be putting on a prescription for these patients. What sort of amounts would be appropriate for a child with cow's milk protein allergy?
Okay, an infant usually needs 900 grams of powder a week, and therefore for monthly prescriptions, the formulas are some of the formulas are available in 900 gram tins, so they would just need 4 tins a month. Other formulas are available in 400 to 450 gram tins, and so you would normally be prescribing 9 lots of 400 gram tins per month.
Lisa, thank you very much indeed.
Thank you.
You mentioned earlier when we were talking about children growing out of these allergies. What sort of ages do you see that happening?
The average age to outgrow milk allergy is about 5 years of age. However, we're understanding milk allergy a little bit better now, and it appears that there's, broadly speaking, 2 types of milk allergy when it comes to immediate type reactions. You've got the milder form, which tends to be outgrown around 3 to 4 years of age, and then there's a minority of children who have a more severe, more persistent form of immediate type milk allergy that often they take with into later life. Now, that doesn't mean it's not going to go away even if you're a teenager. If you look at 12-year-olds with milk allergy, half of them will outgrow it by the age of 16. So it's still worth following these children up to see whether it's outgrown, because it will be in virtually all cases. Now, that's immediate type allergy. With delayed type allergy, fortunately the prognosis is better. Most kids will outgrow these delayed type reactions by the age of 3.
How important is a food challenge for these patients? I mean, can this safely be done in primary care, or is this something that should be done in hospital?
Well, allergy testing is useful, but the definitive test to see whether somebody has developed tolerance to cow's milk is the food challenge. Now again, this is different between immediate type IgE-mediated allergy and delayed non-IgE-mediated type allergy. Because with IgE-mediated, there is always a risk of a severe reaction if you expose a child who's allergic to the food. So we'd normally recommend that if you think somebody's outgrown IgE-mediated milk allergy, that they have their challenge test done under medical supervision. With delayed type allergy, if their symptoms have been mild, eczema, colic, reflux, things like that, we'd encourage those challenges to be happening at home. So from the age of about 1 every 6 months, an attempt at home introduction of milk into the diet. However, if the previous, even though they're delayed type, symptoms have been severe, then I'd still recommend that that's done in hospital under supervision.
Adam, we've talked earlier about the importance of distinguishing between IgE-mediated symptoms and non-IgE-mediated symptoms. And we went through the points of which patients you'd want to see in your clinic. Can we reiterate that again? What sort of patients would you want to see us as GPs referring to you?
Okay, so children with severe forms of allergy. So if that's immediate type allergy, the kids who have had anaphylaxis or who also have asthma as well as their milk allergy, because they're at high risk of anaphylaxis. For delayed type allergies, the ones who have had the more severe forms to the point that they've had rectal bleeding, faltering growth, severe symptoms, those would all warrant referral. I would also recommend referring up children where there's a disconnect between the allergy test and the history, so it's unclear what's going on. And the other group would be children with multiple food allergy, because they're particularly challenging, particularly from the dietetic input that they require. So I think all of those groups should be referred up. That said, I think the children that you hang on to in primary care very much relates to the individual GP's own feeling of confidence and competence about managing this. I think that there are a lot of children with food allergy who can be well managed as long as there's proper dietetic support in primary care, but that very much depends on the individual GP.
So is there a role for testing in non-IgE mediated symptoms?
Not really is the short answer. In fact, one of the things I often see are patients where there is a suspicion on the basis of history of a delayed type allergy, and then the child has IgE tests, which of course aren't really relevant because the suspicion is a non-IgE mediated reaction. And when those tests come back negative, that's falsely taken as being reassuring that there isn't an allergy there. It's incredibly important to ensure that the tests you do relate to the right mechanism of allergy. So if you suspect a delayed type non-IgE mediated allergy, the allergy tests aren't useful. What is useful is, beyond taking the history, an exclusion diet, taking the allergen out of the diet, do the symptoms improve, and then 4 to 6 weeks later, reintroducing cow's milk protein into the diet, do the symptoms return. And that's how we get our diagnosis for non-IgE mediated allergy.
Adam Fox, thank you very much.